Dr. Pilawan, sir.
Sir, can I have your the passport, sir? Are you Mr. Zuki?
Yes.
Tell me about your birthday, sir, for the information.
June 15, 2000.
Okay. So, sir, pasok po, sir. Sir, narito atong lab, ato ang dressing room, sir. Then, napo dito atong patient gown. Then, ang consist sa patient gown, sir, is nasa likod ang outlet. So, pwede mo pangalo dito, sir, sa atong dressing room. Today we're going to demonstrate the cervical vertebrae, AP axial and lateral position or lateral projection or Gratis method, the thoracic vertebrae, AP projection and lateral projection, and lastly is the lumbosacral vertebrae, AP and lateral position. First is we're going to demonstrate the cervical vertebrae, AP axial. So have the patient position upright or supine. So in this video, the patient will be positioned in a supine position. So in part positioning, center the mid-sagittal plane to the IOR. Have the patient place it or at the sides. Then, the center the IR at the level of the cervical fork and adjust a line between the upper occlusal plane and mastoid teeth perpendicular to the IR. Then always remember that you need to shield the gonads of the patient because gonads are sensitive to radiation. So, instruct the patient to suspend his breathing before undergoing the exam, before exposing the patient. Then the central ray must be angled 15 to 20 degrees cephalad, entering the slightly inferior to the thyroid cartilage and existing C4. So, cephalad. Just below the thyroid. So, can we do this one, sir? Face mask, please, sir. Just cephalad. 15 to 30 degrees. So, in this demonstration, we use the 15. And collimate at the level, collimate at the extension. That's our AP axial projection. So, in collimation, adjust the 10 inches or 24 centimeter lengthwise and 1 inch, 2.5 centimeter beyond the skin shadows on side. Then place the marker in the collimated exposure veil. So, in criteria evaluation, the anatomy demonstrated the C2 and T2, the cervical 3 and the thoracic 2 vertebral bodies must be clearly demonstrated on the radiograph. The spaces between the pedicles and intervertebral discs, these spaces are clearly seen. Then, in position, there should be no rotation that indicated by the spinous processes and sternoclavicular joints, if possible. Then, there is an equidistant from the spinal column Final column lateral borders. Then the mandible and the chest, the mandible and the base of the skull should superimpose the first two cervical vertebrae, then the collimation area of the rest. So, in exposure, there is a clear demonstration of soft tissues and bony margins and trabecular markings of the cervical vertebrae. And it is clearly evident that there is no motion in the radiograph. The next position is cervical vertebrae in lateral projection or lateral position, grande, or what we call the grande method. So again, in patient positioning, the patient must be positioned in a supine or standing in lateral position or seated. So in this position, we need to instruct the patient to stand. So in lateral position, adjust the patient's body to 90 degrees lateral. Right. Or left lateral. Then, center the patient at the coronal plane through the mastoid process of the IR. Then adjust the shoulder, horizontal level and body to a true lateral position. Then have the patient elevate the chin slightly. Elevate the chin slightly. Sir. Elevate the chin slightly. Then, and relax the shoulder, sir. Relax your shoulder. If necessary, attach weights to the wrist to help lower the shoulders. Then always remember to shield the gonads before exposing the patient. So the mastoid teeth must be centered at the process mastoid. This is the mastoid teeth. Dapat nakacenter siya sa coronal plane through the center to the eye. The next one is before exposing the patient, we need to instruct the patient to suspend his breathing before exposing the patient. The central ray must be horizontal and perpendicular to the IR, entering the C4 or the cervical 4. The SID that we're going to use is 72 inches or 180 centimeters is recommended. Then in collimation, adjust the 10 by 12 inches or 24 by 30 centimeters. Then place side of the marker in the collimated region. So the central ray must be perpendicular to the mastoid teeth. In collimate, the mastoid teeth. Okay. And that is our cervical vertebrae lateral or grande method. So in anatomical and criteria evaluation, the cervical vertebrae bodies and intervertebral joint spaces, articular pillars, spinous processes, and zygofascial joints must be clearly demonstrated. Then in position, the C1 through the C7 to T1 intervertebral joint spaces are clearly seen. If upper margin of the thoracic one is not demonstrated, additional images such as cervical thoracic lateral should be obtained. The rami or the ramus of the mandible do not superimpose to the C1 to C2. Then in exposure, the soft tissue margins, including margins of the trachea and of the bony margins in trabecular markings of cervical vertebrae, must be clearly demonstrated. Thus, there should be no motion that can be seen in the radiogram. The next position is thoracic vertebrae. Thoracic vertebrae AP projection. In patient positioning, position the patient. It's either supine or standing upright. So today we're going to position the patient in a supine position. Then you must always remember to center the patient's body in the table. So dapat nakasenter ang body sa patient sa table and sa IR sa Then, in part positioning, center the mid-cervical plane to the IR as I said a while ago. Then position top of the IR 1 1/2 to 2 inches or 3.8 to 5 centimeter above the shoulders. Thank you. Then have the patient hold arms at side and shoulders in the same place. So make sure that the arms are on the sides of the patient. The next one is flex the hips and knees to reduce dorsal kyphosis. So flex. Very good. Then, make sure that you always put in your mind that shield the gonads because the gonads of the patient are sensitive to radiation. Then instruct before exposing the patient, instruct the patient to suspend his breathing at the end of full expiration. Then the central ray must be perpendicular to the IR, and the central ray should be approximately midway between the jugular notch and the xiphoid process. So, manipulate this one. This SID is 70 inches. 70 to 72 inches. Then collimate. Then, midway of the jugular notch, the patient's sir, mag-touch ko ha? Okay, great. This is the patient's jugular notch, and the xiphoid process is here. Mag-touch ko sir ha? Great. So, midway. So the central ray must be at midway. Collimate. Then in collimation, adjust the adjust to 7 by 17 inches or 18 by 43 centimeter, then place side of the mortar in the collimated exposure field. So you need to include the next, so in this projection, you need to use a specially designed compensating filters that will improve the image quality of vision. So in criteria evaluation, the thoracic vertebral bodies, intervertebral joint spaces, spinous and transverse processes, the posterior ribs, and costovertebral articulation must be clearly demonstrated, or the anatomy must be demonstrated. In positioning, the spinal column from the C7 to 2 to lumbar 1 centered to the midline of the IR. And there should be no rotation indicated by sternoclavicular joints equidistant from the spine. The collimation of the area of interest must be clearly demonstrated. Then exposure can clear demonstration of the bony margins and trabecular markings of thoracic vertebrae. Then, thus, there should be no motion that can be seen on the final radiograph. The next position is the thoracic vertebrae lateral position. So, position the patient, in patient positioning, position the patient in lateral recumbent position or upright. So, in this demonstration, we use the lateral recumbent position. So, sir, coach ko, so sir, dito na lang sa mga State, sir. State, sir. State naman. And that is our lateral recumbent position. Then, in part positioning, center the posterior half of the thorax, midline of the grid. We place the IR top of IR 1.5 to 2 inches or 3.8 to 5 centimeter above, and make sure that the patient's shoulders must be relaxed. Elevate the head and spine level, extend the arms. So we need to elevate the patient's head for comfortability. For big weight, this one, so place the regions and support. So basically, just make support under lower thoracic region until the spine is horizontal to the tabletop. Then always remember to shield again the bonnets. So in restoration, instruct the patient. The exposure can be made while the patient continues to breathe normally the breathing technique. So to blur the pulmonary vascular markings and ribs or after breathing is suspended at the end of expiration. So instruct the patient before exposing the patient. Instruct the patient to suspend his breathing at the end of expiration. The central ray must be centered to the IR at the thoracic 7. So your thoracic 7 can be palpated at the inferior angle of your scapula. Okay, this is the free angle. So the central ray must be perpendicular to the okay. Then collimate. That's one. Then adjust the collimation to 7 by 17 inches or 18 by 43 centimeter. Then place side of the marker in the collimated exposure field. So in anatomy demonstration, evaluation criteria, I mean, the thoracic vertebral bodies, intervertebral joint spaces, and intervertebral foramina of the thoracic 1 to thoracic 3 will be demonstrated, will be clearly visualized. Then, obtain a lateral image using a cervical thoracic and swimmer lateral if the upper thoracic vertebrae are of special interest. Then, in position, intervertebral disc spaces should be open. Then there should be no rotation indicated by a superimposition of the posterior aspect of the vertebral bodies. Then, there should be no rotation again that is indicated by less than 1.5 inch or 1.25 centimeter of space between posterior ribs. Then, there should be a clear demonstration of bony margins and trabecular markings of the thoracic vertebrae. Thus, there should be no motion overall. The next position that we're going to demonstrate is the lumbar or lumbosacral vertebrae, AP. AP, again, AP, lumbosacral vertebrae. So in patient positioning, position the patient in a supine position. So sir, pag-flip sir, na-after your that is the supine position. Okay. Then part position is center the mid-sagittal plane to the grid. So may grid sa ilalim. Center. Then flex. So then flex the hips and knees of the patient to place back in firm contact with the table. So the reason why we need to flex his hips and knees is to straighten his back. Then center the IR at the iliac crest at the level of the thoracic at the lumbar, L4. So, sir, mag-touch ko ha. L4. So, you can palpate it by palpating your superior aspect of your iliac crest. So, the iliac crest. So, center the loin. So, before exposing the patient, instruct the patient to suspend his breathing at the end of expiration. Then the central ray again must be perpendicular to the center of the IR, entering at the level of the iliac crest. So palpate it mapalpate mo ang iliac crest, dira. Then, in collimation, adjust to 8 by 17 inches or 18 by 43 centimeter, then place side marker in the collimated exposure fields. So, collimate. The next one is, take note that the AP lumbar spine with leaves extended, creating an increased lordotic curvature. So if the patient, if you are going to unflex the knees and hips of the patients, you are going to increase the lordotic curve of the patient. So if you're going to flex his hips and knees, you're going to decrease the lordotic curvature of the patient. So the back of the patient will be in a straight line or straight na siya. Then in anatomy, the SID that we're going to use is 70 inches or 7. No, the minimum SID I mean is 40 inches or 102 centimeter. In evaluation criteria, the lumbar vertebral bodies is bodies, intervertebral joints, spinous, and transverse processes. The SI joints and the sacrum are clearly demonstrated. Then there should be no patient rotation indicated by the SI joints. Then the sacroiliac joints. The sacroiliac joints must be equidistant from the spinous processes, in midline of the vertebral column and transverse processes of equal length. Then there should be a clear demonstration of bony margins and trabecular markings of the lumbar vertebrae, and no motion should be. Always remember to shield the donuts on the patient. The next position and the last position will be the lateral position of lumbosacral vertebrae. So, in patient positioning, position the patient lateral with the hips flex. Lateral, sir. Then hips flex. This is, again, we need to, the hips and the knees of the patient should be flexed to straighten up the back of the patient. So if you're going again to straighten up his hips or his knees, so we intend to increase the lordotic curvature of the patient. Then if we're going to flex his knees, we're going to intend to decrease the lordotic curvature of the patient. Then in part positioning, center the IR to the level of the iliac crest, as usual. Center the mid-coronal plane of the body to the grade. Extend the arms forward. Extend the arms forward. Then, place the radiolucent support under lower thorax. Adjust the spine parallel to the table. Then, always remember to shield, before exposing the patient, shield his or her gonads because the gonads are sensitive to rotation. Then, instruct the patient to suspend at the end of expiration before exposing the patient. Then, the central ray must be perpendicular to the IR, entering the mid-coronal plane at the level of iliac crest. Mid-coronal plane. So, this is the mid-coronal plane of the patient. Center it. 1. Then, in collimation, adjust to 8 by 17 inches or 8 by 43 centimeter, then place side marker in the collimated exposure field. The SID that we're going to use in this position is 40 inches or 102 centimeter. Then the evaluation criteria, the intervertebral foramina starting from the L1 to L4 vertebral bodies, intervertebral joints, the spinous processes, and L5 to S1 junction must be clearly demonstrated. Then, in position, the spinal column must be aligned parallel to the IR as indicated by open intervertebral foramina and open intervertebral joint spaces. No rotation is indicated by superimposed greater sciatic notches and posterior vertebral bodies. Then, the bony margins and trabecular markings of the lumbar vertebrae must be clearly demonstrated. Thus, there should be no rotation in the overall radiographic result or radiographic result. I think that's the point. Thank you.